Good morning, all my friends over there in India, and good evening to all those who are in the United States. And welcome to this 88th edition of our weekly program, the update on SARS COVID-19. And as usual, we have a very large audience over here, almost 100 right in the beginning. And we are very happy to have Dr. Paul Kelly today, who has been giving us an update whenever there is some newer variants that are coming up or some information that needs to be shared with regards to the vaccine. Today, he has been very kind to come over and talk to us on what is there in the variants that we see today, as well as the vaccines, how efficient they are, and what is the status of present vaccines, how we are going to go about the vaccines in future. So for this session, we have Dr. Sridhar Chidamuri to moderate, who will be introducing Dr. Kelly, though he does not require an introduction because he has been a regular speaker on this forum. So there may be some newcomers here onto this particular platform. So it would be good to have his introduction. And I thank Dr. Rammohan also for logging in, and he'll be sharing some of his experiences towards the end. And with these remarks, I hand it over to Dr. Sridhar Chidamuri to conduct the proceedings.
Yeah. Thank you, Sudhakar, and thank you, Paul, for coming. As he said, he doesn't require an introduction, but just in case, Paul Kelly has been my colleague and has also been a good friend of mine. Firstly, he's one of the finest clinicians you'll come across at the bedside. If you're sick, you want no better physician than Paul to take care of you, not just because of his skill, but his compassion and his commitment for his patients. He's a great role model for medical students and residents and whoever wants to be a physician. This is the kind of physician you want to develop into. Paul trained both in New Zealand and in the United States. He is board certified in medicine and infectious disease. He has a personal interest in travel medicine and monitors international travelers who come in with various infectious disease. So he has considerable expertise in it. As far as COVID is concerned, Paul diagnosed the first COVID case we had in our hospital. He was the first one to swab patients, go into rooms, identify the risk and dangers with it so that postgraduates and others who followed him, he made sure that we understand how the infection spreads and the dangers involved because we put young people in harm's way. So that's the kind of person you're dealing with. Today, Paul is going to give you another update on the variants. And also, since we vaccinated a fair number of people, he's going to comment on vaccine efficacy and our own experience with breakthrough infections at our institutions and elsewhere in the United States. So, Paul, go ahead, take it away.
Well, thank you again. I'm honored to speak to you guys all. Good morning and good evening. Yeah, I'm sort of speechless with that opening. It's like, who's this person talking? But yeah, no, it's an honor, and it's been a fascinating time to be a physician general, and certainly in infectious diseases. And you know, us in the Bronx, you know, we've endured this together, and it's been quite an emotional, but also you know, fulfilling experience, you know, for good and for bad. And so, you know, I'm still honored to be here to talk to you guys and to learn from everyone else in dealing with this. As a student of history, I do like to observe sort of the impact the pandemic has had. Certainly in New York City, I always like to see sort of candid photos of sort of how this has changed things and just sort of stop and appreciate the impact it's had on all of us. You know, this photo here, free vaccines, free rides, you know, New York City giving free Metro cards is sort of an unspoken, you know, obstacle, but, you know, here you are, it's motivation to get vaccines. And also there was a monetary incentive back. This is just, you know, on the corner in Harlem, this is, you know, mask shop, basically where you'll see these all over. I'm sure you've seen them elsewhere where, now masks selling is a big business. And probably my favorite is also the impact here on young children. This is a drawing my 5-year-old came home with actually last week that I have it in my office because it's priceless. But the first here is a drawing of a lungs, a whited out lung. They said a good friend of mine got very ill, and actually he didn't have COVID, but I said to her, this is one of the worst ground glass infiltrates I've seen. It looks like a really bad COVID lung. And this was months ago, and it stuck with her. And so she came home for her science day, and she drew my friend's white lungs and also her rendition of coronavirus. So you can see here the impact, on all fronts. So with that, we'll jump right into it. Now, if you remember from the prior lectures that we've had, some things will be a little bit of review, but for the most part, we'll going through as an update. And I wanted to also leave time for us to have a discussion. It's always, an intellectual and great discussion that we have afterwards. But just to summarize, you could see here the new list, and it's populating, week by week, month by month. But you can see here, this is sort of a full list of the variants and variants of interest. Now there's others that aren't listed here, but these are essentially the main ones. And last time we spoke about the majority of these and how a number of these mutations, which we'll get into in further detail, kind of affect antibody response, vaccine efficacy, as well as infectiousness. But if you remember, the D614G was actually the sort of first variant that came out of the parent virus, the D614 Delta, D is in Delta, which originated out of China and then quickly changed throughout Europe and gave rise to all the variants we are faced with today, with the most recent additions being Lambda and Mu, which are now more variants of interest, but not really impactful just as yet. And of course, the big kid on the block is still Delta. We do have a Delta Plus, which has an extra mutation here. You can see the 484Q and the 452R, which is a combination from the Brazilian and California variants. But there's also a new mutation here, the K417N, which is thought to maybe have some more, monoclonal or antibody escape. But doesn't seem to be too much worse than Delta, as you'll see. The big mutations to remember, the 484K, which has been in a number of these variants, still also will factor in. Lambda, there's been new mutations identified. These are novel mutations, the 452Q and the 490S, which are still sort of unsure exactly what their impacts are. But we'll get into all that. But this is just a nice sort of schematic to see where we're at with the variants. So really what we're going to be talking a lot about is Delta, because that's essentially what everyone is facing with now. Delta is now pretty much ubiquitous worldwide. And we spoke a few months ago, we were just getting into Delta in the United States. But, as of this week, it's basically 99% of the cases, accounts for 99% of the isolated cases or sequence cases in the United States. This is a map that was extracted from the New York Times, and basically by state, by far the highest impact has been in the southern states and the Midwest. And this is by hospitalizations, but you can see here the majority being in the Midwest and southern states, which is basically also hand in hand, which mirrors the unvaccinated states as well, the populations with the highest unvaccination rates. And we'll go into that. So we sort of saw this last time with the variants. We definitely know that as these variants evolve, they're definitely more and more transmissible. When the 614D switched to the 614G, there was higher viral shedding and higher viral replication. With the Alpha, which is the UK, previously known as the UK variant, data showed that it was actually 50% more infectious than the prior parent strain. But Delta, when that was compared to Alpha, was actually 55% more infectious to Alpha. So about 100 100% more infectious than the original variant. And that was basically dubbed by the WHO to be the fastest and fittest so far of the variants, with an R0 being about 4 times, maybe it gets higher, but than the 2.5 of the prior variants. As far as severity of illness, Alpha, we had spoken of before, definitely carried a higher risk of death, especially in the older age group. Delta as well, risk of hospitalization is twice that of Alpha. So certainly there's a marked severity of illness. There's an increase in hospitalizations. As of this month, September 10th, CDC's MMWR report also was released, and basically in their data, it showed among the unvaccinated, they were 5 times more likely to be infected, 11 times more likely to die, using their words. So clearly, Delta is much more infectious and lethal, certainly among the unvaccinated, as you'll see in when we speak about specific age groups. And I'm sure you would attest to your own experiences earlier this year. Vaccine efficacy. So I summarized it, what we have now. The data is sort of all over, but there's many different articles that are coming out. There's different numbers and estimates, which I tried to summarize. But for the most part, if we start off with the main 2 RNA vaccines, and I know what concerns you guys with the AstraZeneca, we can see here that the original virus, for the most part, compared to the Alpha, which was the UK, retained most of its activity. So it was virtually the same as far as the efficacy. Now, once you start introducing the sort of similar, the South African and Brazilian variants, you start to see decrease effectiveness. And really that's because of that 484K mutation that they have, where there is more of an escape to the neutralizing antibodies generated both by natural infection and vaccines. And as we'll see, that actually is more so than Delta. So compared to Delta, the antibody escape is actually more with the South African and Brazilian variants, as we'll later see. But for the most part, there is a blunting of vaccine efficacy, and they sort of mirror each other, given these variants are essentially the same. So, you know, with the RNAs, about 75–95% chance of infection, based on some of the studies. With the AstraZeneca, is a little lower. One study back in South Africa, when they were looking at it just in their population, it was about 10%. With the Brazilian, it was around 60%. And with the Chinese vaccine, the Sinovac, was about 50%. So not as effective against those variants. Now, when we look at the Delta, there's been a number of data that has come out regarding the vaccine efficacies, and we'll go into some of these in more detail. But when you're looking at the Pfizer, which has so far some of most of the data, it sort of varies by country. One of the most recent studies out of the UK showed it to be about 88% effective against infection and 96% against hospitalization. The MMWR report that sort of came out actually yesterday, so it was about 77% against infection. And the Israeli study that we'll go into further, which came out last month, showed it was much lower, about 39%, but still very, very effective against severe disease. And we'll go into some of those numbers. With Moderna, it's basically retains that efficacy versus the original virus. So you're seeing about 92%, 95% prevention of hospitalization. Johnson & Johnson is a little lower, which you would probably expect given we'll go into with the technology, but essentially Johnson & Johnson, AstraZeneca used the adenovirus mechanism for delivering the proteins. So they kind of mirror each other with their mechanism of action, and so their efficacy also mirrors each other. You can see here it's about 71% efficacy for preventing hospitalization, but over 90% with prevention of death, which is better for Johnson & Johnson. And initially there was data that showed it was only about in the 30s as far as preventing infection, but the more recent data is a little more encouraging, and it has been much higher for the single dose. This was released out of China with Sinovac against the Delta. This was essentially And this data wasn't reviewed, internationally, but basically 77% chance of preventing pneumonia and 100% in preventing severe disease. But again, this hasn't really been reviewed internationally. Now, against Lambda and Mu, there's really no vaccine data just yet. So we just sort of have to extrapolate based on the mutations that they have as to where they might fall with vaccines. But for now, especially with Mu, it's really only accounting for 0.1% in the United States. It's very low. So we haven't really seen any issues with vaccine breakthrough with these new variants. So we should take a look at the data that came out of Israel. That was in August, because I looked at the number of had the highest number of vaccinees in one of the highest vaccinated countries in the world. So of eligible people, about 78% of Israel is vaccinated, which accounts for about a little over 50% of their total population. So very high vaccination rates. And so when they looked at serious disease, and basically in the time period that they were having Delta, they found that with age over 60 and unvaccinated were 9 times the rate to develop serious disease than fully vaccinated. And with the vaccinated, the odds of infection were actually 3 times higher if about 5 months after dose 2. And so we'll get into this later when we talk about the booster dosing, but a lot of this data is based on the timing of vaccination rather than the vaccine itself failing Delta, or the Delta evading the vaccine. It's essentially a waning of antibodies is the issue. So you can see here the timing of the vaccine. Now, again, when you looked at that figure, initially, it sort of even gave me pause in that, wow, 60% of their hospitalized patients were vaccinated. Like, what's going on here? And when you looked at it, it was mainly a lot of those who were fully vaccinated for over 5 months and in an older age group. So still, some looked at this data and said, well, there's really no difference. Why should I get vaccinated if I'm going to get sick anyway? But it's actually not true, because it's only in a certain age group and in a population that had these breakthrough infections. And what gives you more concern is when you see here age less than 50 with severe cases, not vaccinated, is exponentially higher than fully vaccinated in a very young age group. Again, before thinking this was just the disease of people without medical comorbidities or the elderly, but Delta has totally erased that. So what you're seeing now, and this to give a summary we'll talk about later, is basically younger people, unvaccinated, getting very sick from this or dying, or older patients who are vaccinated, but with vaccine or antibody waning or decay that are becoming infected and having breakthroughs. So that's going to be the theme going forward when we summarize things. But you can kind of see the data here, age over 50, it doesn't change much, although the fully vaccinated are less. So their overall effectiveness was about 85%. So it's 85%, 84.8 with against Delta with the Pfizer. And we'll go into comparing Pfizer and Moderna later on, but you can see here still pretty efficacious. And then we looked at age group, both over 90%. So how about the United States? So this actually just came out along the FDA recommendations, which were released yesterday, which we'll talk about. But basically, it was looking at the vaccine efficacy in the United States, and they were looking at basically only the mRNA, so Pfizer and Moderna. They excluded Johnson & Johnson, and they basically were reporting any positive test if they were 14 days positive after dose 2. So SARS-CoV-2 PCR test positive, it has to be at least 14 days after the second dose. So basically, overall, they looked at it and they saw that the vaccines were 86.8% preventing hospitalization. And when they looked at pre-Delta versus Delta time period, so February to June, there was 84%, and actually Delta July to August 6, where they ended collecting the data, was about 89%. So again, what we're seeing, and this is, I guess, an encouraging thing, is that the vaccines are still very efficacious against Delta itself. It's just basically how much of your antibodies have waned off. How long ago have you gotten the vaccine, which seems to be the issue among the vaccinated. So you can see here, there's a little bit of a decrease in 79.8% age over 65 versus 95% age 18 to 64. So you can see here the age group, age over 65, having much less protection over time. This was another study at NYU where they studied the serum of patients who had COVID or had antibodies, and they compared them to different spike proteins for all the different variants. And they compared them to the 614G, which is sort of the parent variant that evolved all the other variants subsequent to that. And what they actually found, which is interesting, is that the neutralizing antibodies, so these are the antibodies that are generally effective in neutralizing the antigen of the protein that's on the viral wall, essentially were, so in the South African Brazilian variants, and that's why I mentioned that earlier with the E484K, even though that's in the Delta as well, it seems that the other mutations in addition to that have resulted in a much more antibody evasion, as you would. So whether that's vaccine, neutralizing antibody evasion, or natural infection, or both, really. You're looking at across the board against Pfizer, Moderna, Johnson & Johnson, Beta versus Delta, which a much higher decrease in neutralization, versus Delta. So, Delta also had a decrease in neutralizing antibodies, but compared to Beta and the Gamma, there's actually less so. But still, for both, there's a blunting of your immune response. So look at that graphically, because it'll help us to understand. But basically, if you look at convalescence, so these are patients who are naturally infected, and then they compared their blood to the parent variant, which is a 614G, and then you have Alpha, which is the UK, Beta, South African, and then Delta, Delta Plus, and Lambda. And you can see here, anyone with a natural infection have had much less antibody response compared to Alpha or the D614G. So, essentially, if you had natural infection and you were just relying on that to, sort of neutralize these newer variants, you were probably in trouble because it's not going to be as effective. And then when you see here, this is Pfizer, Moderna, and then Johnson & Johnson, you can see here that there is also blunting compared to 614G and Alpha, with the other variants, with neutralization. So, and the mRNAs sort of follow each other, whereas with Johnson & Johnson, it's lower, which again uses that adenovirus technology. And if you separate out by variant, you can see here again, the mRNAs sort of, following each other. With, we'll go into this later, you see the Moderna is slightly higher, especially when you get into Beta, Beta Delta and Delta Plus, and even Lambda. So, you definitely have maybe a little better neutralization response with that vaccine versus Pfizer. But you can see here with the Johnson & Johnson, much lower comparatively speaking to the mRNA technology. So I thought this was interesting also. So neutralization of prior infections. So, we sort of just spoke about this, but again, you could see here that the neutralization against the variants, and which I just mentioned really before, were much lower, than against, if you had a previous infection with the original virus or even the Alpha. So basically, anyone who was infected last year and was relying on their antibody responses to these variants, and even future variants, most likely will either already have had their antibodies disappeared, which I've seen. I actually just had a case following a nurse, and she lost her antibodies after about a year. She went from nucleocapsid positive, and then just negative. So she actually lost hers. But let's say, assuming you still have antibody levels that are detectable, on serologic testing, your neutralizing response will be much lower, will be blunted with the variants. And that, sort of is also followed with the mRNA vaccines, but less so. Now, what about prior infection and vaccine efficacy? So this is basically comparing, there's a preprint that just published last month, and it was comparing the serologies or the neutralizing responses of patients who had natural infection and were vaccinated versus patients who were just vaccinated without any prior infection, okay? So I myself fall into this category, so it's sort of interesting, which is, a number of, I'm sure all of us on this probably fall into this, but essentially what you're seeing, and really just to zoom in on, completing the second dose of, this is Pfizer or the Oxford AstraZeneca. So if there were no evidence of prior infection and you were vaccinated, you had about 85% efficacy, 68%. But you could see here, patients who had, and across the board, this continues, evidence of prior infection, you have actually much higher protection, really. So 85% versus 93, after having Pfizer and natural infection, and 68 versus 88%. So basically, if you're previously infected and vaccinated, your antibody response is going to be higher than someone who is just vaccinated without ever having natural infection. Again, both being very high and protected, but it's interesting to know that, this population will also have sort of extra added, armor. So probably the idea would be if you're infected with the Delta and then vaccinated with one of the mRNAs, you'll be good to go until next year's variants, not to be pessimistic. So, but yeah, it's interesting. And just to go over, they looked at just infections in general, and then the CT value. So this was basically looking at viral load. So what was the cycle threshold of replication? Again, less than 30 is very high viral load. So that was basically looking at someone who had a very high viral burden. And again, you can see, it's not much different, but basically there is a higher amount of efficacy if someone had infection, even if the viral load was high, and even with symptoms here. So you could see across the board that there was definitely added benefit to having prior natural infection. And they all reached statistical significance, at least in this study. So what about Pfizer versus Moderna? So this was an interesting study that came out in the end of August, and it was looking at Belgian healthcare workers, and it was comparing the ones who got Moderna versus Pfizer, and then checking the amount of antibody levels that they had. And you can see here the two groups are pretty evenly matched, mean age 43, 44, mostly females. So I guess Belgian women are smarter, they want to survive all the Belgian chocolate maybe, but for the most part, mostly female healthcare workers in Belgium. And so when they looked at the two, they actually found that the mean, and this was again adjusted for multiple factors, mainly the one I was interested in is the time between vaccination and serologic testing. So that was all controlled for any confounding. But basically what they found is that the mean titers of Moderna versus Pfizer were more than half. So Moderna was more than half of the Pfizer titers, which we'll see graphically, but that reached statistically significant. So what you're seeing is a more increased antibody response with the Moderna vaccine. And probably that's attributable to the actual amount of protein that's in the Moderna vaccine is a little higher. The concentration is higher. So, it does generate more of a potent antibody response based on that. Just to see that graphically, you can see all participants. This is, Moderna versus Pfizer. And so you can see here, definitely there was a higher trend for more antibody titers. This was previously uninfected. So you can see here a difference, whereas previously infected was kind of the same. So their antibody responses were pretty similar, but you could see here that with the Pfizer, there was actually increased amounts. So again, sort of what we just mentioned, that previous infection Pfizer, also pretty good, similar to just, to also previous infection Moderna. For age group, you can kind of see a natural decrease with age as age increases, but again, the Moderna having the higher antibody levels of higher titers in all of the age groups. So we'll move on to vaccine breakthroughs. So the numbers sort of vary. There's a couple of data points that have been published, but for the most part, It seems to be right now less than 2% vaccine breakthrough overall. Let's go through some of the data. So this is data from CDC, and basically initially reported vaccine breakthrough in August was about 1.1%. And the majority of the breakthroughs were in Pfizer, recipient 65%, Moderna 33%, and Johnson & Johnson were 2%. And about 80% were symptomatic. But now what you look at, and this is key going forward with what the recently announced FDA authorization for boosters and what Israel has started doing already since July, is that the number of deaths and hospitalizations of breakthroughs have been predominantly in age over 65. So 87% of deaths from vaccine breakthroughs, age 65 and over, hospitalized but non-fatal, 70% age greater than 65. So you can see here, this is what I want to emphasize, why this number is being so crucial to the decision that was made just yesterday. So what about Delta? So now again, this was actually data from CDC that's been cumulative, so it doesn't really look at timeframes, meaning pre-Delta, post-Delta. But it probably shouldn't matter because Delta, it seems that it's the same with the actual vaccine efficacy. So it's really the timing that they have to look at. How long ago did these patients who broke through get their vaccines? Okay, so that's the key. So if you look at Israel's data, they had and this is basically only using Pfizer, that Israel uses is the Pfizer mRNA vaccine. Their breakthrough rate was about 1.8% in the total population. In July, they also published their vaccine breakthrough data in healthcare workers, which was lower, about 0.4%. But the caveat to that is that this data was mostly at a time where it was the Alpha or the UK variant that was in Israel. So 85% of the sequenced viruses were actually Alpha and not Delta. So, I would say that the breakthrough rate was probably a little higher if you start adding Delta to that, now, but probably not much more so. Again, it's going to be timing. You can see here the groups, nursing, admin, maintenance, and then physicians. Of the breakthrough cases, 26 or 67% had mild symptoms and 0 hospitalized. Now, what was interesting in this was that they actually looked at what were the antibody titers, that the mean titers where patients, these healthcare workers started having breakthroughs. And so this is something that, we are sort of using as well. But they looked at basically the majority of those breakthroughs occurred when their antibody titers were less than 200, like 198. So again, it's really difficult to interpret because you don't know, when you're checking a simple blood test, the serologies, you don't know how much are actually neutralizing antibodies. But for the most part, when they measured this, if you had neutralizing antibodies less than 200, that's when they started to see a lot of the breakthroughs. So, that kind of gives a little bit of a window to maybe how to interpret some of these antibody testings that we're doing when you start seeing the quantitative results. This was another study that was just released first of this month. This is coming out of San Diego. So this is vaccine breakthroughs in healthcare workers. Hopefully it's not being blocked yet. So basically it was looking at the vaccinated healthcare workers in the San Diego health system. And they looked at it by time period. So they looked at it basically where they saw a lot of the positive tests shoot up starting in June, and this correlates with basically Delta variant. So you could see that, pretty dramatically. When you look at the actual groups, you could see they basically looked at it by month. So March, April, May, June to July, and June being sort of the end or the beginning of Delta and the end of the Alpha that was in the United States at least. And so essentially what you see here, the attack rate, which is what I want to emphasize, what you can see was relatively for vaccinated workers and unvaccinated workers. For vaccinated, it pretty much stayed the same until you see June, it starts to trickle up. And then in July, full on Delta, you go from 0.3 to 5.7 per 1,000. And then with unvaccinated, it's sort of hovering in the 4 or 5 range, and then it shoots up to 16.4. So clearly dramatic impact of Delta, not to be trifled with, definitely to be respected, because in both groups, regardless of vaccination, the rates, the infection rates dramatically increase. What was interesting is actually the symptomatic cases were more in the vaccinated versus the unvaccinated. And I would argue that the reason they were more is because the ones who broke through were probably the older population, because the study doesn't go into that. But those who broke through were symptomatic, because they probably had, they were in a higher risk age group, and they had time of vaccination was probably, was prolonged. But you can see a very dramatic impact of Delta for healthcare workers. So of those who were symptomatic, 83.8% were vaccinated versus 88.9% unvaccinated. There were no deaths, and one unvaccinated person was actually hospitalized, which I would expect, knowing Delta and seeing all the data. This actually, they got lucky, thankfully, but for that, a lot of the unvaccinated, they not get so sick, is certainly lucky. What about our own experience? So we actually just last week had our first healthcare worker who broke through. He was symptomatic, mild disease, and he received Pfizer, young resident. And so that's our first healthcare worker breakthrough. As far as our inpatient, we've been following it. Since I just cut off, so we've had a few pre-June, but I just went from June on because I really wanted to see the impact of Delta. And there's only a few cases before, and then all of a sudden, June and plus is where we start to see a lot of our breakthroughs, which makes sense with the data we just saw from San Diego. So, so far in inpatient, we have 19 cases, and the majority of our Pfizer breakthroughs, which is our 11. 3 ended up going to ICU, 1 is intubated, and the ages range, from 30s to 84. What I think is striking, and what we're seeing as the highest risk factor, is being overweight or obese. So the majority of those cases, 72.7%, were BMI over 25. Okay, so and that seems to be the predominant risk factor. There's cardiovascular disease, et cetera, sort of spread out, but for the most part, in these younger cases, 34, 40-year-olds that we'll get into, the only real major risk factor was obesity or being overweight, was high BMI. 9 were completely vaccinated, and 3 only had 1 dose. So these gotta get eliminated because Delta is so good at breaking through after just 1 dose. It's really sort of closer to a more natural infection than vaccine breakthrough because the antibody levels aren't that high yet. But even still, 9 were completely vaccinated. Moderna was less, so total of 5 so far, 3 in the ICU, 1 intubated. Again, age range 40 to 70, majority 60%, BMI over 25. 5 of them completely vaccinated, 1 of them with just 1 dose. As far as Johnson & Johnson, there have been 3, 1 in the ICU, and that was a 35-year-old, just to comment. 0 have been intubated. And again, all 3 of them, 100% BMI over 25. So I think that's the main take home I've been seeing, that is that in addition to the age group, which we were talking about, I think high BMI is also has been a risk factor for this. As of September 16th, 20% of the hospitalized COVID cases are vaccine breakthroughs. So, we have obviously unvaccinated who don't do well, but 20% of those cases that are actually in hospital are actually vaccine breakthroughs, which is high. So let's talk a minute about monoclonal antibodies. How am I doing on time? We'll run over we're almost done. So basically, the main monoclonal antibodies that we use now, the Regeneron, which is the carasivimab and imdevimab and sotrovimab used for outpatient. The Regeneron is also approved by FDA for post-exposure prophylaxis. Bamlanivimab, etesevimab have been actually eliminated as of 6/25/21. They're no longer recommended because of the beta and gamma. So it's the South African, Brazilian variants, which are resistant, have escaped to these. So these are no longer recommended. And I put here for completion the criteria, but for the most part, you're probably aware of all the criteria here: age over 65, obesity, diabetes, chronic cardiovascular disease, etc. So we had spoke about this last time, and that in June we had received, again, that bamlanivimab and etesevimab were resistant mostly with the beta and gamma variants. However, still susceptible to Regeneron. More recent data from July, and this is that study that I had mentioned before from NYU, actually found even with Regeneron, there was blunting of neutralizing antibodies. So Regeneron is also, not as good against these variants. So the beta, there was a much more decrease in the neutralizing response. Look at Delta, 92.7-fold decreased neutralization. So, I think we're going to have to be careful. Our use so far in the outpatient has been positive, but I think as these variants evolve, we should probably not rely on these monoclonal antibodies too much, which will may weigh into something. We looked at this last time as well, but basically this is just summarizing what I had just mentioned, and that there was definitely a decrease in potency of these monoclonal antibodies against these variants. Okay. And again, just to look at it again, so these two are out. These are the combination therapies. But if you look, this is the Regeneron. You can see here mostly it's the beta, which is the South African that has blunting, and that seems to be what I had mentioned before, that the mutations with the beta allow more of an escape, which is sort of given worry about the mu, because the mu variant sort of has similar mutation as beta, so there might be more escape of this variant to the monoclonal antibodies and antibodies from the vaccine. But you can see here all the other variants maintain their activity, or these monoclonal antibodies maintain their activity against the majority of the other variants, including Delta. So this was interesting. This is an article I read today regarding monoclonal antibodies, that there's actually, it's being relied on so much, especially in the South, as sort of this magic bullet, where people are avoiding getting vaccines, knowing that they can just get a monoclonal antibody treatment, which is actually putting a lot of strain on hospitals, because even though it's federally funded, to actually infuse these requires space, requires infusion nurse, and time and things like that. So costs aside, the dose demand has actually really increased, and I think this is more of a testament to just Delta really taking a hold and spreading like wildfire. But you can see here that there were 27,000 doses per week requested in July, and that's jumped up to 168,000 doses per week in August. And the southern states are accounting for 70% of those orders, which is predominantly where Delta is raging. Allocated doses, most of these states in the South are asking for much higher doses than they're actually allotted. You can see here the 15,000 doses were needed. They only allowed less than half. Florida, they were 41,000 doses short of their weekly allotment. So really, really high demand for these southern states. So just to go into vaccines, now I wanted to define what actually it means versus a third dose and a booster. So basically a third dose is what we're going to be using when we talk about a patient who has received the initial vaccine series, but their immune response was not adequate enough to generate protection. So they require a third dose to get that protection. So that's really going to be, targeted to the groups of immunosuppressed, patients with cancer, et cetera, which we'll go into. The booster dose is basically a dose that is given to an individual who received the series and had an adequate response. And now that that antibody level the effect is actually waned over time. So you're getting a booster to essentially generate that protection again, okay? So last month, the FDA did authorize the use of third doses for special population groups, which we'll get into, mainly just with Pfizer and Moderna. And there wasn't enough data yet on the Johnson & Johnson one-dose series. But we can see that data, why it actually, why the data was actually looked after was essentially what you see here with the immunocompromised, and that's versus healthy controls. The antibody levels in immunocompromised are much less, with vaccine compared to controls. With the predominant, which intuitively makes sense, the predominant population being an organ transplant, having a very, very low antibody response after the two-dose series. Hematologic malignancies, leukemias, lymphomas, sort of coming in second, and then the immunosuppressive therapies and dialysis patients. So you can see here, compared to healthy controls, much more blunted antibody responses, which intuitively makes sense after the series. There was a randomized controlled trial giving a third dose of Moderna to transplant recipients. About 120 received it versus placebo. And what they saw was clear benefit after they got Moderna mRNA. The antibody levels were much higher versus placebo in the group that did not get the vaccine. You can see here before and after versus placebo. So clearly there was a benefit. 33 of 60 patients were 55% antibody levels. They used the titer over 100. Remember, we sort of spoke about less than 200. So you're sort of seeing in that ballpark 100 to 200 being the level of protection that you want versus 18% placebo. So clearly a benefit in this population. As far as harms, there really weren't any additional harms that were experienced between second and third doses. So the main ones you can see here: pain at the injection site, which anyone who's got that vaccine will attest to, relatively the same after the third dose. Fatigue being the other sort of second reported adverse effect. Fever, not so much, although that's a very common complaint, but really the fatigue. So essentially the third dose didn't seem to be, at least in this study, causing much grief, although I think we've been hearing some rumblings of third dose causing symptoms in other patients. Now, who is it indicated for? Just to go through this. So solid tumor hematologic malignancies, solid organ transplant on immunosuppression, immunosuppressive therapy, CAR T cell suppression, moderate severe primary immunodeficiency, but really here, especially a population that I see every day, HIV/AIDS population, and mainly using the CD4 less than 200, which is used for other vaccines, live vaccines such as yellow fever or MMR. So really, anyone less than T cell less than 200, should be given the third dose. And someone who's on chronic steroids greater than 20 milligrams a day, or other immunosuppressive therapies here. So what about a booster dose? So now this is leaving the immunocompromised, getting their third dose. This is a booster dose. So this is basically patients who have already had an adequate immune response, should they get a third dose. So Israel and in August 2021 started doing this, started giving booster doses. And it was basically based on some data from Pfizer and their own data that showed that third dose was 86% effective in people aged over 60. And that was basically for disease, and that was patients who received the full vaccination series. They got their third dose 6 months after their second dose. And what they found in this study is that the loss of vaccine efficacy wasn't because Delta was super strong at just breaking through. It was actually a waning of the antibody levels, which is what I've been mentioning before. So you can see really here, the point 2, the vaccine efficacy decreased with increasing time, irrespective of the variant. So the breakthrough infection rate was 53% higher in early versus late vaccinees, and that was statistically significant. And the vaccinated were 2.6-fold higher risk for breakthrough infection in January versus April. So if you're vaccinated in January, you're at a much higher risk, more than double the risk versus April. And what was key here is the effectiveness against Delta hospitalizations remained high over the entire study period. So it wasn't Delta itself, it's basically Delta plus getting the vaccine a long time ago. Now, this is already outdated, but I have an update slide after. But when I wrote this, CDC pending FDA authorization, which was really, can we get a second dose? But just to be complete, this is basically what CDC is officially saying right now. With Johnson & Johnson, they need more data. Now, as far as mixing vaccines, this is something maybe we'll talk about later. There's really no data on that, although some countries have do it. I believe in the UK, they've started mixing, mainly if someone got a Johnson & Johnson, can they get the mRNA, et cetera. With AstraZeneca, there is data from June that actually showed a third dose does boost immune response, but there hasn't really been any major trials after that I've seen. So just yesterday, Pfizer was approved by the FDA here in the United States for age group greater than or equal to 65 years old, or if they're high risk for severe disease, which did include healthcare workers and actually teachers. And just to compare, Israel has actually been giving booster doses to all age groups, all eligible, greater than age 12. So that's a little bit of a difference that you're seeing here. And there's definitely ongoing debate about, who should get a booster dose. But the data definitely supports giving Pfizer vaccinees over the age of 65 a third dose, a booster dose. And that's basically it for now. And I just wanted to leave off with, because, this will be to continue. There's no theme. This I just saw started yesterday. So this is actually in the National Mall in Washington, D.C. And I thought it was quite moving. There's actually an art exhibit where they put up over 660,000 white flags representing all the people who died in the United States, and just to sort of honor the lost. And it definitely kind of moves me, and to have seen this. So it is something that I think we should all be aware of, and maybe even visit if we can. So with that, we can start the discussion. Apologize for taking a whole hour.
Ram, you want to start off, or you want me to start? Your microphone is muted.
No, you're going to lead the chat box discussion, but I'm very eager to ask Paul one question regarding yesterday. The Pfizer data, Pfizer submitted to CDC that produced that recommendation over 65.
Right.
Is that because Moderna did not submit data? It would be almost identical if they did, correct?
Yeah, so I think it just isn't as much data. And I think Pfizer was disappointed because they wanted it to be the age 12 and above to just sort of vaccinate everyone. But when you really looked at the data, it didn't seem necessary based on that. So I would say with Moderna, it's actually probably going to be a little bit longer, because I think for the most part, Moderna, they started vaccinating later than Pfizer, if I'm correct. They were around the same time, but I think they probably are going to see that it might not be as bad. Obviously there'll be some patients, but I think that given what we're seeing with the antibody response from the vaccine, that the rate of decay is probably a little longer than Pfizer. So I think it remains to be seen. I mean, definitely needs to be more data. It might be something where Moderna would be, instead of like 8 months after, maybe it's 10 months or a year after, you have to see. But for the most part, it's, as of now, it's just with Pfizer. Right.
Sudhakar, you have any questions?
Yeah.
Right.
Yesterday, actually, we have had a recommendation here in India not to go for this booster dose, for the reason that there might be more variants coming up if you start taking the booster doses without completing the vaccination process to the entire country. So would the third dose invite more of these variants which are stronger? Is a question from my side.
Yeah, and that echoes the WHO. So the WHO obviously has the world's interest at mind. So they would rather see the majority of countries get fully vaccinated rather than allocate supplies to start giving the booster doses, because there's still a high amount of unvaccinated, countries and populations that, are completely unprotected. So, I would agree. I think it's the first step is to try and get everyone vaccinated. The reality is you're probably always going to be playing catch up if you don't have everyone vaccinated, because the variants will probably continue to evolve, as we spoke about, given the very high rate of mutation, in prior times we've spoken. So, I think if it comes to, obviously, ideally, you want to vaccinate everyone, and then anyone who should get a third dose should get it too. But I think if it's going to be a supply issue and you can only allocate doses, unvaccinated versus booster, I mean, certainly the unvaccinated should get priority, because as you could see with Delta, it really is quite aggressive. And, basically the mantra coming out of the South, and I was reading an ID doc who wrote, it's basically quicker, sicker, and younger. That's what they're seeing. And so anyone who's unvaccinated is really going to be, high risk with Delta. So, I agree with WHO. I think there should be an allocation for unvaccinated populations than boosters.
So, go ahead, Ram.
Sridhar, I saw your post in Facebook yesterday, and I was relating to Sudhakar's question just now to clarify to the audience, third dose versus booster dose. So a moment ago, I think Sudhakar said third dose. You meant booster dose, didn't you?
Right, correct. Booster dose. Yeah, so third dose, just applies to basically the immunocompromised or someone who got the 2-dose series but didn't generate enough antibodies appropriately. Whereas booster is essentially anyone else who's received the vaccine series, generated adequate response, but now it's waned over time, so they get the booster. Right.
Yeah. So, Paul, now that Delta has spread all over the world, do you think actually having Delta is actually an advantage? Because it's basically suppressed all other variants. It's 99% of infections in India, 99% of infections in the United States, and it's continuing to spread like that. Is it in a way suppressing all other variants from emerging?
Correct. That's what has been going on now. I mean, it's definitely the, you know, how the analogy you want to put it, but, you know, major kid on the block. It's out, and it's almost like it's the right virus, it's the right variant at the right time. You know, that's sort of what, you know, a virologist I was reading about, you know, had stated, because there probably will be some future variant, and Delta will lose its foothold, you know, at some point. But for now, it's just the perfect storm, you know, especially an unvaccinated population, you know, for it to really propagate. Now, you know, will Mu or Lambda or some other future variant take over? You know, that's anyone's guess right now. That would just be, you know, trying to foresee the future. But I think the way this is going, certainly vaccinating, and if you survive Delta, having antibodies from infection with Delta will sort of, you know, give you some protection versus the next, you know, variant, whatever that may be. Even Delta, I mean, you know, if you're unvaccinated and you haven't faced Delta yet, you can't even think about what is after that, because you'll have a real, you know, fight on your hands, you know, to try and get through Delta, you know, Delta's infection.
Is Delta more virulent? In your experience, are you seeing it to be sicker by any means? I mean,
yes, so sicker and quicker, and you know, I think that was something we had discussed before, that you guys had seen when, you know, went from 10 days severe disease to day 5 having severe disease, and that echoes with me, and I think that's what, you know, we have seen, for sure. So I think it's definitely to be respected.
So if you go back to the Israeli data, they seem to show a lot more long COVID on breakthrough infections. Like 20% of them develop long haul syndromes after breakthrough infections.
Right.
Would that worry you?
Yeah, I mean, I think with the trying to go, but I didn't really touch on that too much. But with the long haul, it's one, it's unpredictable who's going to have it, and 2, it seems to be antibody mediated. I believe, like there's probably some circulating ongoing inflammation that's occurring. You know, we've seen that, you know, when you break it down by organ system, you know, with cardiology, there seems to be a lot of ongoing inflammation in the myocytes. You know, with the lungs, obviously you can see infiltrates, you know, up to 3 months, not too often. I think the majority of symptoms that are bothersome for patients aren't really these major organs. It's essentially just these, you know, sort of vague symptoms like feeling chronically fatigued and tired. That's the main common complaint. The anosmia and dysgeusia rather, you know, that persists for months in some patients, where they can't taste or smell anything. They still tell me they can't taste or smell. That cognitive fog, you know, which is actually really what's been striking, is against young patients who've had it, you know, the difficulty concentrating, etc. So, you know, I think myself personally, I still suffer from sleep disturbances. Like I just wake up randomly in the middle of the night, which I never had before after COVID. So I think, you know, now as far as, you know, well, treatment, really there isn't much as far as major treatment for it, but I'm not really sure I've seen any data about vaccines preventing that. I guess it's because it's obviously from natural infection. So, if you break through with a vaccine and get an infection, it's still possible, I think, to get some long COVID symptoms. But, I think that's something that we would have to, monitor for.
So let's talk about healthcare workers in India. 2-3 questions on it. There's one on the chat, but I'll start with one. Would you, in India, healthcare workers took an enormous burden during the second wave. Would you recommend that they get a booster dose at some point? It is recommended in the United States, right? When healthcare workers were also approved for third dose.
Right.
What about healthcare workers in India? That's the first question. At what stage would you recommend it? Number 2, they got mostly AstraZeneca, and
right.
the Indian one, Covaxin. In Britain, what they're doing with their healthcare workers is they mostly got AstraZeneca, right? But their booster will be a Pfizer. So one dose, but it'll be a Pfizer dose.
Right.
How should India go about mixing and matching vaccines? And first, let's talk about Indian healthcare workers.
Yeah, absolutely. And I mean, I definitely, empathize with what you guys went through, and absolutely. I mean, I think, if there can be access to a second dose, it should be given, ideally, to protect you guys, especially with the vaccination rate still being low, albeit increasing. Yeah, and that's what I had seen too in the UK, that they were mixing. So again, there isn't a lot of data yet that I've seen about it as far as like randomized trials, but it makes sense because the technology is different. So with the AstraZeneca and Johnson & Johnson, as I mentioned before, it's the adenovirus vector, which is transferring or carrying the antigen for your immune response, versus the mRNA, which is quite different in that it's just delivering a piece of DNA or RNA rather, that's going to change the DNA and create the protein. So I think it definitely would be the way to go because of the data that we know. You'll have a more potent antibody response from the mRNA vaccines. So intuitively, and what I'm seeing with the data, I think I agree with it, and I think it makes sense. I think for it to be fully adapted, at least in the United States, there's going to be a lot more scrutiny on the data. But it seems to, I think it's going to be something that will probably eventually take hold for anyone who has access to the mRNA vaccines. But I think for in India, I think there's data that I had mentioned before, where with the adenovirus, a second dose does generate more antibody response. That was released from AstraZeneca from Oxford. But I think it's whichever you can get would probably be the best case scenario.
Yeah. So did the government of India said no boosters for healthcare workers too, or just the patients? So who are they referring to?
Yeah, it's for everyone. There is no separate category that has been made. It is not available to anybody.
Right.
Okay. I think the question is it okay to use a different vaccine, say after?
Sorry, I'm sorry, I missed the last part.
Sridhar, your audio is out. Your audio is out. Sridhar, your audio is out.
I think I see right here. The question was, is it okay to take a different vaccine, say after 6 months, from the second dose of the initial vaccine? So yeah, I mean, that's basically what we're seeing, the data 5 months and out, or after 5 months, with the mRNA, Pfizer mainly, that's when the booster dose was given, not the third dose, the booster dose was given. So I think it's going to be, I think in Israel, they've been using it 6 months. The United States still has to actually officially said what time period, although the Biden administration is looking at 8 months. So I think it'll probably be 8 months. But yeah, the data, it seems that it's 5 months and out, that the benefits there.
Okay. Anyone else has any questions when you don't?
See that the way I read C. Nagesh's question, I thought, if you took Covishield or Covaxin first, after 6 months, can you now take Pfizer vaccine? I think.
Oh, different. Right. Yeah. So I would say, I honestly don't know. We don't have the safety data on it. The UK is doing it, so I suppose they'll be the first to publish that. But I think intuitively, it would probably be safe. I think you might experience some of the side effects that you would get after dose 2, because it's a one-time dose. But I think otherwise it'll probably come out that it's safe to do so.
Yeah.
If someone traveled from India, having already had 2 doses of Covaxin, the person is now in New Jersey, 75-year-old. Should he get Moderna, or I assume it would be again Moderna, 2 doses. It should.
Yeah, that's what.
Okay.
Yeah, I mean, I think either mRNA, but Moderna seems to have the more potent antibody response.
And a related question for this season is a time gap between the booster shot and flu shot, the annual seasonal flu shot. Time gap should be how long, and can you give it, same week?
So, yeah, I mean, for one, our flu season last year was very, very mild. I don't know what this year will bring, but that being said, I think priming your immune system with the flu vaccine is probably helpful. I think that's going to be somewhat of a strategy with children who aren't yet eligible for vaccination, at least getting the flu shot. Not that it will, carry over to COVID, but at least their immune responses will sort of be primed a bit. As far as the timing, really, CDC, and as far as knowledge with vaccines, there was some initial hesitancy to try and mix the vaccines, meaning to give one of the COVID vaccines along with another vaccine. But there's really no absolute contraindication to that. The only caveat would be if you're giving a live vaccine. So like with some of my travelers with yellow fever, or I think with, I guess it really doesn't apply, but like, let's say an adult who doesn't have MMR, you might want to space out the live vaccines with the COVID. But, I think if it came down to it and you couldn't wait, I would opt to just vaccinate someone with the COVID series first. But, really the flu season at this point right now, today, like if I, go to work Monday, we're ordering the flu vaccines, but I would definitely want to make sure that patients got their COVID vaccine. If it had to be absolutely at the same time, same day, I would feel comfortable doing that. I don't think there would be any really major blunting with that, so.
Yeah, I think so. I think Moderna is actually working on a flu and COVID combination shot. I'm told it's supposed to come out anytime soon. So a combination of flu and Moderna in the same one shot. So I think there should be no problem with interference with the 2 vaccines.
No.
Yeah. Any other questions?
Sridhar, there is a question from Dr. Naveen. Dr. Naveen, speak up.
Go ahead.
Hello, everyone, sir. Thank you for the opportunity. Wonderful lecture, sir, Dr. Kelly. Sir, I'll just read out the interim position statement of WHO on booster shots, sir. Latest position statement that came out. In the context of ongoing global vaccine supply constraints, administration of booster doses will exacerbate inequities by driving up demand and consume scarce supply. While priority population in some countries or subnational settings have not yet received as primary vaccine series. Thus, the focus for the additional doses should be based on individual consideration of the individual series, vaccine waning, vaccine antibodies waning, and all those, sir. It has softened a bit, sir. WHO, that has softened a bit, sir. All along, it has been saying there is no booster doses. Now it has just softened up, sir. Individual countries can take a call like that. It has come out, sir. That is the latest position statement of the WHO, sir. That is the latest, sir. Individual countries can take a call based on their national policies. That is what it has come out. At least it said up to the end of this month, don't talk about booster dose at the end of this September.
Right. No, thank you very much. Yeah, I mean that is new for WHO, and I think you used the right word. They're softening up slightly. You know, I think it is based on country, situation. I still think that the priority is higher in unvaccinated, because you're just going to see much more devastation with unvaccinated populations. But obviously, if supply isn't an issue, if you take that away, then yeah, I agree. I mean, totally, the distribution should be to whoever the data indicates. So unvaccinated, obviously, age over 65, immunocompromised, et cetera, to get the third dose or booster. So, I think it's going to have to be, it's going to be a question of resources, really, depending on where, where the population is.
So
yeah,
there's some more good news.
Yeah, go ahead.
So there's some more good news for we Indians, sir. More and more experts, more and more scientific bodies are coming with the projection and predictions, sir, that there may not be third wave for in India, or the surge or the peak. And we are more optimistic now, sir. That more and more body, even CMC Vellore as latest as last week, they said there's no scientific basis for projection of a third wave in India. That's what they are saying, sir. Taking all considerations, all the data into consideration. That's what CMC Vellore has said this week, sir. And several other public health bodies also are coming with this projection, sir. We feel more optimistic, sir, and more hopeful, sir.
Okay. Yeah, I was going to say, do you agree with their projection?
Thank you, sir. Thank you, sir.
I just want to say something about that. I think the third wave will be much milder for sure if 1 billion people are vaccinated. I'm sure it won't be as bad as the second wave that we saw in India. But I think Sudhakar kind of pointed out something that you're ignoring. He just said 100 people were tested randomly who were supposed to be allocated to do election duty, and 30% of them tested positive. That's your first warning sign that it is not gone away. It's asymptomatically sitting under you. That's
I think we lost him again.
Yeah. Sridhar, yeah.
Audio was lost. Sridhar, your audio is gone.
And continue to have, pardon me?
Your audio was gone for the last 15 seconds.
Okay,
Yes.
I think it's So just that's the warning for us, as I was saying, to continue to wear masks, continue to maintain social distancing, and push vaccine as much as you can. I think don't ignore 30% of people testing positive on your screening. In the United States, it's less than 10%, and we are seeing huge waves in unvaccinated people in the US. So I think don't become complacent because some public health institution said something. They really don't have the data to support it, to say whatever they're saying they will be or they will not be. The proof is actually vaccinating and wearing masks. And I think once people start saying there's no third wave, people tend to become complacent. And we've been burned again and again with these things. You have to learn from mistakes.
And I just wanted to add too with Israel that when they went into their second wave, after their vaccination rate was so high, they completely opened up as if the pandemic was over. So there was, everyone had vaccine cards, et cetera, but they were eating in restaurants and closed areas, no masks. So, I think it went a little bit to the extreme. I think as Sridhar just said, it's vaccination plus continuing with wearing masks and sort of, if there's really, really large gatherings, to really be more careful, et cetera. And I wanted to mention that because the Israeli data, also has to be taken with that they basically, stopped, sort of honoring the other measures. So, vaccine alone versus vaccination plus, mask wearing, really.
Yeah. One other point I want to make, I think, Paul, we talked about it. So this business of obesity and breakthrough infections, one of the things that we want to study more is that whether this is because the needles that were used to vaccinate people were too short, that instead of giving intramuscular injections in obese people, we ended up inadvertently giving subcutaneous injections. And that is why in obese people, vaccines have failed or failing. Or we just postulating that. We obviously will do more analysis as we get more data to either prove or disprove that. But I think in the meanwhile, I just want to suggest to all the vaccine sites that if you're giving vaccines to people who are morbidly obese, make sure you're using longer needles so that you actually are giving intramuscular injections and not subcutaneous. In the United States, it's a common practice to use that single needle. In fact, I didn't see any in our vaccine sites, people changing the needle when they're dealing with people who are obese. I hope India has a better strategy, and if you are not using longer needles, you may want to switch for obese people.
So I agree. I think that's a very good observation, and certainly something that should be studied because it definitely makes sense. And
so one more question allowed, sir. One more question allowed, sir. Sir, I heard a speaker saying from the breakthrough infections, hospitalization were more with Pfizer vaccines. Is it correct, sir? Did I hear it wrong, sir?
Yes. So the majority of the data with vaccine breakthrough has been higher with Pfizer. I think mainly it's probably two reasons. It's timing of vaccination, which is also leads you to the second reason, which is that the antibody response is clearly less compared to the Moderna, the mRNA. So I think those are the two factors which are, basically implicating, or the word, that is showing that Pfizer is definitely going to be a little bit more common to have a breakthrough compared to Moderna.
But all said and done, hospitalization shouldn't have been more compared with other vaccines for the most efficacious vaccine in the world, no, sir. Whatever odds you have to neutralize, whatever these things, but still it would have been.
Yeah, and so we're talking mostly about infections versus hospitalization. I mean, hospitalizations are still relatively low among both. I can go back to that, but basically with infections, it seems that with the breakthroughs with Pfizer are definitely more.
Okay, sir. Okay, sir. Thank you. Thanks for that clarity, sir. And one more of late in the social medias, this been viral, sir. Efficacy were natural infection and efficacy with vaccine induced antibodies. Thank you for dispelling all those doubts, sir. People have been thinking vaccine, natural infection is better. Of late, this is circulating in the social media, sir. Thank you for giving clarity on that, sir. vaccine-induced protection is many times better than natural infection. That is your statement,
Vaccination.
sir? Yes, sir. Yes, sir. Yes.
Okay.
Thank you, sir. Thank you, organizers, for permitting.
Yeah. Any other question before Sudhakar? You can close it otherwise.
Sridhar, one question, not directly related. It's almost a year and a half we have heard about diabetes. Is there any data on badly controlled diabetes, well-controlled diabetes, relationship with low A1C, high A1C? Is it diabetes or bad diabetes?
And I think bad diabetes, I think the emerging now data showing bad diabetes to be worse than diabetes. Yeah. So I think bad diabetes do worse than just diabetes. I think that's what we're seeing now as we collect more and more data.
Somebody actually differentiated by A1C.
Yeah, by A1C, yeah.
Very good.
Yeah.
So Sridhar, if you don't
Again, diabetes in the P group who are less than 50 tend to do worse than diabetes in people over the age of 50.
Great. Thank you.
Yeah.
Paul, once again, on behalf of Dr. Sudhakar and Andhra Medical College and Sridhar Chilamuri, thank you for coming on board. Every time
My pleasure, as always.
you give clear information and guidance. Dr. Sudhakar.
Yeah, thank you very much, Dr. Kelly, for such a wonderful presentation and dispelling all the myths that people have, and expressing your own opinions as well, and giving the latest from the CDC as well. And thanks a lot. And I wish that you would come again, maybe after a few weeks, with latest information that we have. And,
yeah, absolutely. Honored.
Yeah. Thank you, Sridhar, for conducting these proceedings so well and answering all the questions. Thank you, Ram Mohan, for chipping in with your comments and appropriate questions, which are basically that usually crop up in everyone's mind. Thanks all those who have logged in for this particular session, and we will meet again the next Sunday in India, IST 6:30 a.m. and the Saturday night in United States. Until then, bye-bye. Thank you very much.
Thank you very much. Be safe.
Bye.
Okay, thank you, Paul. See you Monday.
My pleasure.
Yeah.
Take care. Yeah.
Bye-bye. Thank you.